learn the actions of the hip, the muscles that do the work, and the nerves that innervate them. Let's start with hip flexion. Hip flexion is a great movement for kneeing your enemy in the groin. Hi-ya! Hi-ya! The principal muscle that contributes to flexion of the hip is the iliopsoas muscle. This is a muscle found along the posterior abdominal wall, so we frequently forget it's a muscle of the lower limb. It's actually composed of two muscles, the iliacus and psoas major, but inferiorly, the muscles converge to form a single belly. Its distal attachment is to the lesser trochanter of the femur, so when the muscle contracts, it's the most powerful of the hip flexors. The iliopsoas is clinically relevant because it can help assist with diagnosing abdominal pain. You can see from the image that a retrocecal positioned appendix is in close contact with the right iliopsoas muscle. If the appendix becomes inflamed, the fascia surrounding the muscle can become irritated, making movement of the muscle painful. A physician who suspects appendicitis might try to elicit a Psoas sign to support their diagnosis. This maneuver requires that the patient either flexes their thigh against resistance or allows the physician to passively extend their thigh, as illustrated here. If either stretching or contraction of the muscle elicits pain, the patient is described as exhibiting a positive Psoas sign and might be an indication of appendicitis or an iliopsoas abscess. The second muscle that contributes to flexion of the hip is rectus femoris. Keep in mind that this is the only head of the quadriceps muscle that crosses the hip joint and thus is the only head that participates in hip movement. Proximally, the rectus femoris attaches to the anterior inferior iliac spine, as illustrated here. This is significant because this is a location in which an apophysis develops. What's an apophysis, you ask? It's basically an epiphysis. However, rather than contributing to a joint, as does an epiphysis, it develops at the location of a tendinous or ligamentous attachment site. Avulsion injuries, or pulling away of the anterior inferior iliac spine, as imaged here, can result from forceful flexion of the rectus femoris muscle. This injury is most common in adolescent males involved in some kind of kicking sport, such as soccer or my beloved martial arts. Innervation of both the psoas major and rectus femoris muscles are via the femoral nerve. Thus, a proximal injury to this nerve will result in reduced hip flexion strength. L2 is the main contributor to the hip flexion myotome. Thus, an injury to the L2 ventral rami will also result in reduced hip flexion strength. Now moving on to hip extension. Sneak up behind me? Not a chance. Gluteus maximus is the most powerful of the hip extensors. It is also the most superficial and largest of the gluteal muscles. Innervation of this muscle includes the inferior gluteal nerve, and injury to this nerve makes normal extension activities difficult, such as standing up from a chair or walking up the stairs. All three of the hamstring muscles cross the hip joint on their way to attaching to the ischial tuberosity, and thus all three contribute to hip extension. Specifically, the hamstring muscles include semimembranosus, semitendinosus, and biceps femoris. The short head of biceps femoris does not cross the hip joint and therefore does not contribute to this action. Avulsion fractures of the ischial tuberosity are another potential injury in adolescent athletes due to the hamstring's attachment to this location. The bottom image on the right illustrates this avulsion injury. A portion of adductor magnus also serves as a hamstring and thus also contributes to hip extension. Innervation of all the hamstring muscles is via the tibial nerve. Now moving on to hip abduction. While hip abduction is vital for the ballerina and even the side kick, perhaps the greater significance of the hip abductors is stabilization of the pelvis during the swinging phase of gait.
During gait, there's always going to be one extremity that comes off the ground, and then that side of the pelvis is unsupported. In this example, we're going to talk about the abductors on the left side of the hip. So when I raise my right limb, my right side of the hip is now unsupported, and if my abductors are paralyzed on the left side, the hip will fall to the right hand side, the unsupported side, because the abductors are responsible for keeping the hip horizontal during that swing phase of gait.
So what are the hip abductors? Gluteus, medius, and minimus. Both of these muscles attach proximally to the gluteal surface of the ilium and distally to the greater trochanter of the femur. Innervation of both of these muscles comes from the superior gluteal nerve. Injury to the superior gluteal nerve results in a Trendelenburg gait. As Dr. Fitz described, this is a pattern of walking in which the hip drops to the unaffected side as the foot is lifted off the ground. Now on to hip adduction. Come on, Dr. Fitz, take that. The list of hip adductors is rather extensive and includes all of the muscles in the medial compartment of the thigh. The most superficial of these muscles includes pectineus, adductor longus, and gracilis. The deeper of these muscles include adductor brevis and adductor magnus. Innervation of the medial compartment of the thigh, and thereby the adductors of the hip, is via the obturator nerve. The position of the obturator nerve along the lateral pelvic wall places it in a vulnerable location during childbirth. A forceps-assisted birth, or even the head of the fetus itself, can compress the nerve leading to injury. In such an instance, the patient may present with paresthesia over the medial thigh or weakness with hip adduction. The obturator is also vulnerable during pelvic surgery, for example, when removing cancerous lymph nodes from the lateral pelvic wall. Now on to lateral or external rotation of the hip. The lateral rotators of the hip all have one thing in common, which is that they attach somewhere on the pelvic girdle and then distally to the greater trochanter of the femur, or just below. These muscles include piriformis. As a block, the superior and inferior gemelli with a tendon of obturator internus lying between the two. And lastly, quadratus femoris. Take note of the close proximity with which the sciatic nerve resides in relation to the piriformis muscle. Typically, the sciatic nerve is described as exiting the pelvic cavity just inferior to the piriformis, as is indicated by the arrow in this image. The sciatic nerve can also pierce through piriformis, although this variation is less common. This is clinically relevant because a tight or spastic piriformis muscle can compress the sciatic nerve, resulting in pain and or paresthesia along the posterior thigh, leg, and foot. This condition is referred to as Piriformis Syndrome. Exercises that focus on stretching the lateral rotators may help to decrease the painful symptoms. Obturator internus is also of clinical relevance. An inflamed appendix that is situated in the pelvic region may come in contact with the muscle and cause irritation. In such an instance, movement of the obturator internus will elicit pain and is known as the Obturator Sign. To perform an obturator test, flex the patient's thigh at the hip and bend the knee. Then rotate the leg internally and externally at the hip. If there is an inflammatory process adjacent to the obturator muscle, pain is elicited. And lastly, medial rotation. In addition to abduction of the hip, both gluteus medius and minimus also contribute to medial rotation. An additional muscle that we haven't yet discussed also contributes to this action, which is the coffee muscle, otherwise known as the tensor fascia latae. It's actually called the tensor fascia lata, but it's much funner to say the previous. This concludes our look at the actions of the hip.